Hello, Nick Majerison here, and this is Top Med Talk. Welcome along. We have an absolutely brilliant Top Med Talk for you today. It is a roundtable highlight, and it's the Maryland Funding Experiment. If you haven't heard of the Maryland Funding Experiment, this is going to be absolutely fascinating to you. And if you have, you're bound to have opinions on it, which we'd like to hear. I'll give you details of that right at the end of the podcast. Anyway, in the meantime, let's have a little listen. This was recorded live on the first day of the EBPOM USA Masters course. It features Desiree, Chappell, Monty, Mythen, Dr. Lee Fleisher, Chair of Anesthesiology and Critical Care at the University of Pennsylvania, and Vicki, Morton, DNP and Director of Clinical and Quality Outcomes at Providence Anesthesiology Associates, University of South Carolina. Have a listen.
Top Med Talk. Maryland.
Yes.
We've heard of Maryland in the UK because I think it was one of those early places where the Brits were allowed in for a while.
Okay.
And that's why it was called Maryland. But what the Maryland Healthcare Experiment, which you highlighted for us brilliantly, but I think if we could share it to a broader audience, that would be great.
So Maryland, they have two academic medical centers, but the most famous being Johns Hopkins, as well as the University of Maryland, has for decades had an experiment in which all the payers agreed to pay the same price for a hospital room, and that the hospitals essentially would be held harmless in that they couldn't make too much money, but they couldn't lose too much because they would adjust the price that the insurers would pay based upon the needs. So when they came into this value-based healthcare, they actually negotiated with Medicare to do an all-payer transition to getting a global budget before the year starts. And that budget would be based upon the number of patients that are assigned to your hospital. And you had to figure out how to deliver all care.
So I think that's where we are in the UK. So I think we get a capitation fee for your population. They
Correct.
say, there's a chunk of change, get on with it, now make it work. We're not saying it's perfect in any way, shape or form, but you've got some control over spend, resource, how to best use it. That's unique in the USA, is it?
That is unique for that state, but there's some outs here, couplefold. One is if you get international patients or patients from other states, you can charge whatever you want and make the money. The second one, and this is very relevant for the Hopkins of the world, if you do unique things like transplants, it's incredibly expensive. So I'd be curious in the UK, do they regionalize it? Because depending on what you do for the patient can cost you a lot more.
Yeah, there are special tariffs. So certain categories, transplant would be an example, very unusual surgeries. There are national tariffs that then get moved around, so you bid for them to do a number of transplants per annum. But it's separate from that capitated fee for doing every day of the week joint replacements, the regular cancer surgeries, etc.
So we're still trying to figure it out. In Maryland, the issue is that in 2019, the previous administration, so we'll see what will happen, actually said not only are you going to be responsible for the spend of the hospital, but you'll be responsible for the spend of the doctors for those same capitated patients. So the issue is those doctors don't necessarily work for the hospital.
How are your providers play a role in this, and how are they kind of getting paid? I mean, it's a very general question.
And they get paid the old-fashioned way, but the hospital's on the hook that they could lose money because your providers attached to those patients will be spending more. So this is really trying to align us very similar to the British system.
How much are the hospital systems pushing to bring those surgeons on board as part of as being hospital employees versus private groups?
I think they're trying to figure it out depending on the hospital and the primary care providers, which are probably even more important than the surgeons. And that's the interesting experiment, because in the U.S., what's happening is consolidation. So we've got all these big systems buying up other hospitals, and how can they work together? So it's a grand experiment. It would save a lot of money for our system if we went there, but everybody's watching Maryland because it's the only state that has this.
Are they sharing savings? So are they able to do that on the other side? If the surgeon does everything that they're supposed to do, follow all the protocols and standards, and they actually save money? Or is that something that's going back?
It depends on the system. I know a little bit about Hopkins, having been there, and they're still trying to figure it out. But they, I will tell you, at Penn, we actually have that. If we have savings on a service line, we share it back with the docs. But there are some anti-competition laws, Stark laws about self-referral, et cetera, that we have to get around to see whether or not we can share some of those savings.
We know incentivizing sometimes is a good way to get people on board.
Yes.
So I have a question. We recently went through a situation where the insurance provider, because with our bariatric program we were doing so well and saving so much money, they reduced our reimbursements by $400,000. That was not an outcome I was ever expecting to happen. And I'd like to know what your thoughts are on that.
So that is an outcome I expect to happen because we have to bend the cost curve. So you almost have to go in with the question because the other thing they can do is just switch it to an outpatient procedure.
And we are.
And you are. And then every time you renegotiate, you can negotiate a new fee. And we have this with the hospital, and I do a lot of our negotiations for our system. So you really have to make them understand in the negotiations that if they get too aggressive at dropping the payment, there's going to be no incentive for innovation. So that's the key, is making them understand that we want to bend the cost curve. If we can get it down, that's great. But if you get too draconian in how you pay, there will be no more innovation.
Right.
And that's a recurring discussion in our system. You have to maintain that the salaries, the quality of staff, you have to have an irreducible minimum. You have to keep something in the system that funds innovation, or it all gets completely stifled. It becomes commoditized, and that's a downward spiral, I think.
What other industry only spends 1% to 2% or less on innovation? Apple doesn't. The drug companies don't. And, we think a lot about radiology. I mean, I actually think they're a group that as we get better, we're going to need less radiologists and we're going to need less post-acute care. Do we give them a soft landing? Do we actually say to our radiologists, we're going to pay you to work less, and in 5 years we want, as people retire, just don't replace them?
Because I'm guessing that the computers can do the radiology interpretation pretty damn well if we let them get on with it, with a bit of AI support.
It's not about that. It's actually, do you need as many X-rays? I mean,
that's
on the pre-op clinics and the post-op.
No, it's true. Yeah, I mean, you're just assessing patients more aggressively and not just doing a blanket order for every single patient. I mean, you need to assess whether or not they truly need it.
We don't have a pre-op clinic.
Oh.
Our physician, our surgeons probably over-order tests.
Yeah.
So before we move on from Maryland, one thing you didn't say is whether, if there's a league table of results, are they mid-table, bottom of the table, top of the table? If they've got this system and it sounds sensible economically, are the outcomes better or worse?
They started out not quite as good.
Okay.
And they're getting into, I think, the average range, but they're still studying it.
Okay.
Interesting.
Is it a good model for the rest of the country, you think?
The doctors are not yet aligned with the health systems. I think, is it a good model for the UK?
It's like all of these things. We seem to be spending relatively little money compared to the USA on healthcare, and our outcomes appear to be a lot better overall. And part of that may be the distribution of our social services spend compared to the health spend. Part of that may be because people in the food chain are paid a lot less money. Who knows? But even if you look at the very crude metrics of live births per 100,000 or whether overall length of life is going up or down, big picture is we seem to be doing all right.
But you probably use less resources.
Yeah.
And the question is, how quickly can we get people to realize that, not doing something is okay?
Right.
We're not there yet.
Top Med Talk. So that piece is taken from a longer conversation, which you'll be able to find if you go to topmedtalk.com. And if you do go to topmedtalk.com, you'll also have a chance to sign up for our email updates. It's an essential way, really, for us to keep in touch and to tell you when we are live streaming from the website. So if you're not part of that, you're not yet fully part of Top Med Talk. They're entirely free and they keep you in touch with your favourite medical podcast. Also, of course, I mentioned before, we're looking for audience feedback on the question of funding healthcare. It's a big issue and we'd like to know your thoughts. contact@topmedtalk.com. contact@topmedtalk.com. Tell us whereabouts in the world you're listening and send us your point and then potentially hear your thoughts on a future edition of Top Med Talk. Also, of course, you can meet the Top Med Talk team. All you need to do is go to the EBPOM website, ebpom.org. That's ebpom.org/meetings. Once you're there, you'll find a list of all of the events that we will be in attendance at. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September, ebpom.org for more details. That's ebpom.org.